Welcome to Inside the Studio, the official podcast of the Texas Heart Institute at Baylor College of Medicine. I'm Dr. Joseph Rogers, and together we'll explore the ever-evolving world of cardiovascular care. In each episode, we bring you conversations with the people shaping the future of heart and vascular health, cardiologists on the front lines of patient care, surgeons performing groundbreaking procedures, and scientists leading discoveries that will change medicine for generations. We'll also highlight perspectives from international leaders and community voices who share our commitment to preventing, diagnosing, and treating heart disease. Whether you're a physician, a researcher, a patient, or simply curious about the latest in heart health, this podcast is your inside look at innovation, education, and care at the highest level. So let's step inside the studio. Well, hi, I'm Dr. Joe Rogers, the director of the Texas Heart Institute at Baylor College of Medicine, and I'm joined in the studio today by Juan Lopez, who has recently come to the Texas Heart Institute as one of our valuable recruits. Dr. Lopez leads the advanced imaging group here at THI and specifically focused on cardiac CT and MRI. And we're in the studio today to talk a little bit more about advanced cardiac imaging, particularly in patients who have had an oncologic condition. So, Juan, thanks for joining us in the studio today.
Thank you, Joe. I'm honored and happy to be part of your team.
Well, we're very fortunate to recruit you back. So, and welcome back to Houston.
Thank you.
So, I was really intrigued by your grand rounds today. I think there are a number of things that we can touch on, but I guess a couple of questions for you. You laid out at the beginning of your talk sort of a series of tests that patients should have and sort of alluded to the timing of them. But I wonder if we could backtrack and go over that again, just to sort of emphasize your point. A lot of these patients are starting off in an oncology practice, go through dramatic therapies that are complex, right? Some people will have surgical therapies, some will have chemotherapy, and I think you highlighted very nicely the vast array of anti-neoplastic agents and the potential for different kinds of cardiac injury. And then you also touched on radiation. So in an ideal world, Juan, what does that cardiac care across that continuum look like, starting from when a patient has a diagnosis to the time that they are cancer-free and sort of the follow-up of their cardiovascular condition? Outline what that looks like for us.
Definitely. No, thank you, Joe. So basically, you have the first stage is when they are getting staged. They identify they had malignancy. So the pre-treatment aspect of it is that we have to. That's the biggest opportunity that we have to identify what this cardiovascular risk this patient has that he's bringing, to the treatment. And then when the treatment starts, so they already know what they want to do with the patient, depending on the biopsy results and all that. So the treatment aspect, we know what the patient is going to get. So we know the most common cardiovascular side effects and what we should look into. And then the survivorship, the follow-up and the survivorship of it is that what is going to happen with this patient years down the road. Meaning that if the patient received, for example, radiation treatment or was in a drug that could be associated with coronary artery disease, how that surveillance is going to look like depending on the risk factor. So I think there's different windows of opportunity that we can intervene, and we always have to think in those terms, and not only I saw the patient, I gave my recommendation, goodbye. Mm-hmm. No, there has to be a continuous therapeutic relationship between the cardio-oncologist and this patient, and the oncologists have to be aware of this windows of opportunity too, so we can mitigate the high cardiovascular morbidity or mortality that this patient have.
So I thought you made a really strong statement about assessing baseline risk for coronary artery disease or for cardiovascular disease or atherosclerotic vascular disease. But you also have made a strong case for longitudinal follow-up and the fact that it's helpful to have a strong portfolio of baseline information to help you interpret subsequent studies. So, I mean, obviously echo is the most accessible imaging tool for most cardiologists who are seeing these patients. And the reality is, most places don't have a cardio-oncologist. And this is general cardiologists that are filling that important, sort of gap in this patient's journey. So what are the right tests that our colleagues should be doing as they're getting referred patients in that early stage after a diagnosis?
Sure. No. So basically, when they're very early, so they present to your clinic. So there's one very useful piece of information that you should have, despite of the patient's symptoms, which often they come without symptoms, but the oncologist is concerned that the patient might have some sort of risk, and is if there's coronary calcifications in their scans. Very important data. We made a strong case that the radiologists reading this cancer imaging test, they should mention the presence or absence of coronary calcifications, because that's a lot of information and it can help us make informed decisions. And if the cardiologist is able to look at the scans themselves and qualitatively assess the extent of the calcification and how much calcified plaque the patient might have, then perhaps that can help them make decisions in regards to preventive treatment, because often this patient might not be in anything, or this has not been explored, or when you talk to them, suddenly you identify, oh, I'm getting short of breath. Yeah, I'm having all these problems. So I think that particularly that first encounter with available imaging scan without you ordering a test is important. The other thing is let's use the tools that we know that work, like the ASCVD risk score. Certainly in this population, our sense as cardio-oncologists is that it underestimates risk. But there's something that you can quantify and you can use and make informed decisions. And perhaps this patient, after the first encounter, you start statin, which we know in the long run, statins are a very potent tool to prevent cardiovascular morbidity and mortality.
So you've talked a lot about the vascular impacts of the therapies, but what about the myocardial impacts? Should these patients be undergoing an echo at baseline, or should they be getting some other kind of advanced imaging study as they enter into some of these pathways? And again, to help us understand if a year later they begin to get symptoms, we have a baseline study.
I 100% agree. I think that an echo is an important diagnostic test, particularly in patients that are going to receive potentially cardiotoxic medications. So a baseline echo will be very helpful, because then down the road, if the patient comes with heart failure and you have an ejection fraction of 30%, you don't have a baseline, then you're stuck. You're like, where is this coming from? So 100% I agree that the baseline echo with strain will be very appropriate in patients that are going to receive treatments like anthracycline, HER2 treatments. I think for our breast cancer patients, I think it's very important to have this baseline echo with strain, and then the follow-up will be mostly there are algorithms that we follow that are evidence-based that we can use to inform how often we should image this patient. So I think that if we do all those things, we certainly can monitor the patient, and often they're going to come to you with the concerns because they Google the name of the medication they're going to receive. Oh, this is anthracycline, the red devil. Oh my God, this is, they become very concerned. But, often my role is to partner with the oncologist in regards to make sure that the message is the same across the board. Yeah, there's a risk, but it depends on the dose, and we're going to monitor it and establish this therapeutic relationship with the patient, that we have to reassure them and tell them, yeah, there's some risk, but this is the best that we can do so far. And if they're deciding on using this treatment, is for the better. Not like I will avoid to have strong reactions, because am I concerned? I'm concerned when someone is going to be starting astrazeneca, but I know that there are not only safe ways to do this, but also there are other ways that we can identify early problems and then intervene, and then patients are going to do great. So our role is not to obstruct or intervene necessarily I try not to opine on that cancer relationship, treatment relationship, but I'm here as a facilitator and help monitor and make sure that everything that is going is going for the better of the patient.
So we've touched on sort of using echo and MR in particular to follow this patient population, but you also highlighted for us some really intensive recommendations about how to use cardiac CT in the follow-up of these patients. And I wonder if you wouldn't mind just walking us through the high level, and then Juan, how do you integrate all of this? So there are several different modalities. How does the practicing cardiologist begin to weave this into a way so that we can really have a holistic perspective on how the patient's cardiovascular system is responding to the therapies?
No, that's a great question, Joe. I think that certainly, there's some guidance provided by the European Society of Cardiology, which is the society that has like a proper guideline for this. I think that the important thing is that it depends on what type of treatment the patient is receiving. I think that the monitoring of echo becomes very relevant. The other situation is for coronary CT, specifically for most nowadays with the new chest pain guidelines, we know that coronary CT is like a first-line test for patients that are presenting with a chest pain and they're stable. So I think that the same applies to oncologic patients. Now, there are there's these new technologies that we use that we're going to soon have here, the plaque quantification. We currently have FFRCT. All those things are important, and perhaps even in the general population, we're still figuring out how we're going to use this plaque quantification technique. So I think that there's certainly certain things in CT that are very well established with symptoms. But in asymptomatics, I still think that we should be very careful in what we tell our patients if they should get a coronary CT or not, because insurers are not going to pay, if it's not appropriately ordered. And right now, for asymptomatic patients in coronary are looking for coronary artery disease, there will be very few instances where you're going to get an approval. So I think that we have to keep that in mind. But also, the other thing is that these patients tend to have a lot of vascular complications in the cath lab. And that's very well robust data shown by my colleague Cesar Iliescu in MD Anderson. And by me working with him and others in England, we proved that these patients tend to have, when they go to PCI, they tend to have high rates of vascular complications. So we know that. So CCTA is a great option because, we just stick a vein. It doesn't require a lot of resources in the sense of with the cath lab. And then you have a great patient experience and a very potent diagnostic test.
So I want to turn, as we close, away from the clinical parts of the care of these patients and talk a little bit about some of the interesting and exciting research that's going on in this space, especially as it pertains to cardiac imaging in the oncology patient. And I guess I would love to know from your perspective, what are the big gaps that we have? And I'll frame this up this way. It would seem to me that we are so well aware of this important connection between malignancy and cardiovascular disease. And you hit on it beautifully at the beginning of your grand rounds today. Do we have registries where we're collecting longitudinal imaging data in this patient population when a new chemotherapeutic agent comes on the market, and many of them have cardiovascular effects? Is there a cardiovascular registry that's actually collecting this data that we can continue to learn from?
So there's a ongoing registry supported by the International Cardio-Oncology Society, ICOS. I know that the main PI is in Cleveland Clinic, Florida, and they have this. It's a big effort. They're basically doing a lot of this. Using their own resources, because it's very hard to get funding for this type of thing. But they have gotten some funding. So there's an ongoing registry with different clinical aspect, imaging variables. So there's those efforts, and there's also individual institutional efforts that are monitoring these type of things. Also, there's been some data using in clinical trials using MRI to assess certain changes, particularly ejection fraction. So I think there's certainly, we're getting more sophisticated as we move forward. At the same time, we're not at a registry level kind of data, and we probably will never be anytime soon. Now, maybe with AI, things will change, but I think that right now, because of the heterogeneity of our population, different drugs, different malignancies, the genetics play a role. Like, very recently, and not very recently, but you've heard about clonal hematopoiesis of indeterminate potential, which is a risk factor for cardiovascular death and high calcium score. And this is something that is an interlap between preventive cardiovascular care and oncology. Now, in the oncology arena, there's a little bit of a higher risk of hematologic malignancy, but the cardiovascular risk is higher. And often, patients in their 60s are the ones that they present with this risk marker. So I think those things, we're going to start identifying certain inflammatory pathways in common that are going to continue to come up because atherosclerosis, inflammation, neoplasia, inflammation. So it makes a lot of sense. I think at some point we might end up in the middle with the oncologists. I feel that actually the oncologists, the way they approach disease is very interesting because they are very personalized. Mm-hmm. I think we're moving in that direction now, particularly with this plaque imaging. Like, we're trying to find, like, we're still rely a lot on randomized clinical trials, but at some point I think that there's other types of registry data, there's other comprehensive data that we're looking, and we want to be more personalized because we know that not everyone is going to behave like the average, and that's where I feel like we if we keep moving in that direction, then our practice is going to look very different years to come.
Yeah, I think you really highlighted and touched on precision as part of your grand rounds today, and I agree with you that we're extrapolating what will happen to an individual from a population-based study, and you're right, there has to be a spectrum of response to whatever it is we're studying. So I always learn so much when I have a chance to talk to you, and again, I'm appreciative that you took the time to give grand rounds today and to spend some time with us in the studio. And Juan, we're so happy to have you at the Texas Heart Institute at Baylor College of Medicine. So I look forward to working with you more and watching you continue to advance the space of advanced cardiac imaging.
Thank you, Joe. It's a pleasure and an honor to work with you and our great team.
Thanks.